everybody. This is Professor Ghulam Siddiq. Today we're going to present a case of a 28 years young lady who presented to our outpatients clinic with 3 months history of upper abdominal pain, dysphagia and vomiting. These symptoms were initially mild but gradually got worse. She underwent laparoscopic sleeve gastrectomy about 12 months ago. At that stage, her weight was 115 kgs, while her current weight was 69 kg, and the BMI was nearly 30. She was thoroughly investigated. These investigations included an upper GI endoscopy, upper GI series, and a CT scan of abdomen. They were all suggestive of a stricture at the level of incisura of the stomach. She was counseled for laparoscopic Roux-en-Y gastric bypass. Standard 5 ports technique was used, a 10 millimeter port for the camera and two 12 millimeter ports as working ports in the mid-clavicular lines, 5 millimeter port in the left anterior axillary line for the assistant, and a 5 millimeter port was used for Nathanson retractor. The stomach can be seen here, densely adherent to the undersurface of the left lobe of the liver. The incisura, the part of the stomach distal to the incisura is grossly dilated, while the remaining proximal part of the stomach is twisted in an anticlockwise fashion. The adhesions at places were flimsy, but higher up they were very dense. All these adhesions were taken down. Combination of both blunt and sharp dissection was used. We made sure that we stay in the right plane. The stricture part of the stomach can clearly be appreciated here. Here the dissection was quite tedious, as there was no plane between the stomach and the undersurface of the liver. I stayed more on the liver side and encountered some ooze, which was controlled with electrocautery. Once the pouch was fully mobilized, a micro pouch was fashioned for Roux-en-Y gastric bypass. A window is then created close to the lesser curvature of the stomach, about 5 centimeters from the GE junction. Stomach is then divided using an endo-GIA linear stapler in a horizontal fashion. To resize the pouch, another load was used in a vertical direction. Posterior to the staple line, gastrotomy was then performed. The omentum, as expected, was not very heavy. It was pushed up above the transverse colon, and the ligament of Treitz was identified. A BP limb of 70 centimeters was measured in clockwise manner. At this point, it was anchored to the omentum, and the remaining bowel was measured up to the ileocecal junction. The total bowel length in this case was nearly 6 meters. Enterotomy was then performed, stay suture removed, again a linear stapler was used for gastrojejunostomy. Gastrojejunostomy, I always make sure that it's not more than 3 centimeters. A stay suture is then taken at one end of the common opening. This acts as a stay suture for retraction, while at the same time it reinforces the staple line. 3-0 V-lock suture is then used for closure of the common opening. Peterson space is next closed with a purse-string suture of 2-0 proline. A rule limb of 100 centimeters is then measured and then side to side jejunostomy is performed. For closure of the common enterotomy opening, I use 30 Maxon single layer in continuous fashion. The BP limb is then divided close to the gastrojejunostomy, about 1 to 2 centimeters away from the lateral end of the gastrojejunostomy. Leak test was performed, which was negative. She did very well following surgery and was fit enough to be discharged the following day. On follow-up in the surgical outpatients clinic, her symptoms have fully resolved now. Thanks for watching.